Hi, good afternoon, everyone, and thank you for joining us today with our hypertension case finding webinar. For those of you that don't know me, my name's Lindsay. I'm the Healthcare Development Manager here at CPLSC and have quite an extensive background in nursing. I was a paediatric renal nurse for about 5 years, so I've just completed a project with the team, Hypertension Hustle project, which you may have seen on our newsletters. So this has been a nice way to round up that project and sum up some of the things I've found whilst I've been out and about. And one of the things I have noticed is a lot of pharmacists out there, you're taking on the sole responsibility of this service and you don't need to. So this is a fantastic opportunity for all members of the pharmacy team to just brush up on their knowledge and develop some new skills, and hopefully then more people in your pharmacies will be confident in delivering the service and give you a helping hand. So this session will cover some of the background of hypertension and the risks that we know there are. And it will also, I'll go through some case studies and just things to look out for and just handy tips and tricks. For those of you that have team members that are probably still working right now, we always record our webinars, which you'll have noticed pop up in the left-hand corner of the screen. So we will save this, it will go onto YouTube and you'll be able to watch back on demand. So a little bit of housekeeping, because we've done the webinar style a little bit different this time. If you see at the top of your screen, there is a chat function and there is a Q&A function. So any questions you've got, pop into there and I'll go through some at the end. I have got some frequently asked questions that we've pulled off CPE and things as well, just to go through. And again, some of these have been asked whilst I've been out and about, so it'd be good to cover those. So let's get started. So why does hypertension case finding matter in community pharmacy? So we know that CVD is one of the leading causes of premature death in England, and we know it accounts for probably around 25% of the life expectancy gap, which in today's day and age with today's medicine and healthcare is absolutely crazy. And we know that hypertension then is the biggest cause for CVD. As I've mentioned, so it's in the top 5 risk factors for all premature death and disability in England at the moment, which affects around 7 million people and accounts for roughly 1.5 million disability adjusted life years. Roughly 5.5 million people have undiagnosed hypertension in England. So the majority of the people, you walk past in the street, you can kind of look and think, you could have hypertension. People you work with, you could think you have hypertension. And without services like this, we're never going to have the opportunity to detect this early. And then obviously that goes on to lead to CVD, unfortunately. It's often known as the silent killer because patients usually feel completely fine. And as I say, you'll probably come across a lot of people that pop into the pharmacy, a lot of patients, and they say, oh, no, I don't need my blood pressure checking because I feel fine. But that's why pharmacy teams are so important. And we may be the only people that patients engage with for their healthcare. They may not feel unwell, so they're not seeking a GP appointment or other medical review. So that's why it's so important that we jump in any opportunity that we can and offer these blood pressure checks. So who to screen? We're looking at patients mostly over 40 who request the service. They might pop in. They are aware of the service being provided in community pharmacy. They might have a family history of hypertension. So that's a great opportunity to say, well, we know you've got a history, let's just have a check. Adults over 40 who don't have a current diagnosis of hypertension, and adults with or without a diagnosis of hypertension if they're referred by the GP. So we've got some great GP partners at the moment that are being really proactive in referring into the service, and that's saving them a lot of nurse hours and obviously is beneficial for us in pharmacy. So it's really important to be upskilling all our staff, dispensers, technicians, anybody on the counter, to have that confidence in offering those checks and hopefully providing those checks as well. So people that are just coming in for the over-the-counter purchases, and Dave's coming for he's got a cold, but he looks like he might be over 40, so we're just offering your regular customers that you can build a bit of a rapport with, and then often, we can check in with them regularly as well. Every sort of 3 to 6 months is great. So if any of you are familiar with Menti, we've done a little bit of an interactive poll for this webinar, just to get a little bit of a sense check of who we've got on the call, who might be providing blood pressures, who might not be. So if you grab your phone or a tablet or whatever and just scan the QR code, it will bring up the Menti webpage. And then if you just pop in the code, which is 19745059, it'll just give you a little question to fill in. As I say, that's more for us to have a bit of a sense check of who we've got on the call, and just see if, those conversations we've been having out and about people gaining that confidence and other professionals getting involved in the service, that would be really appreciated. So the question is, do you currently check blood pressures in your pharmacy? And we've got yes, regularly, occasionally, or not yet. And we'd really like for those of you that have, selected not yet, that by the end of this webinar, you might have the confidence to have a go in practice. Just give everyone a couple more minutes because I know it can be slow sometimes. We've got a really mixed bag actually, so that's good. And then I know that the rest of the webinar is going to appeal to everybody. So naturally, with every service, there are financial benefits. I'm very aware that ABPM machines at the moment are quite costly. Prices start at around £800. However, if you look at the financial benefits we've got with the service, half of that cost will be covered with your setup fee. So that's £440. Then you get £10 per clinic blood pressure check. And naturally, if we're leading on to do an ABPM, we've done a blood pressure check first. And then you get your just short of £60 for your ABPM provision. So by the time you've taken your setup fee out of it, if you've got a good few patients that you can get on board and you've had those conversations with your local practices, you can have it paid off, in a couple of weeks, a month maybe. So although that initial, purchase cost looks a little bit daunting, it can be, and I've seen that it can be paid off pretty quickly, and then you're into your profit margins then. So how can we boost the service in your pharmacy? So as I've mentioned, work collaboratively with your GP practices. Let them know that you're doing the service, have a discussion with them. We always, as your OPC, encourage you to have those open discussions with your GP partners. And actually, we've found a real increase in GP practices referring into the service, which is excellent. And the feedback we've received from them is they are saving a lot of time, which is great because they can get on with other things, like their nurses can be on with chronic pain management, they can be on with ECGs, cervical smears. So it's very useful for them as well as you, for them to be referring into the service. So if we can upskill all staff to recruit patients into the service and deliver the service, as I've said, you could triple your workload, I suppose. You could have certain staff on certain days that are allocated to the service, or somebody could be the lead on the service, and then that's taking the pressure off the pharmacist primarily. And then we want to be offering the service to all eligible patients. Now, we don't like to assume that somebody looks of a certain age. However, when we've worked in healthcare, we can kind of have a little bit of a gauge on who looks like they might suit the service. And there's absolutely no harm in asking if somebody comes in for an over-the-counter medicine, or your regular patients that come and pick up their prescriptions. You tend to know how old they are anyway. So it's just about offering and selling it in a way that's, really convenient, and it'll only take a few minutes, and it's really helpful to check. And really emphasising that most people with hypertension don't know that they've got hypertension. And once you build those relationships and that rapport with your patients, they're more likely to come back to you, not only for this service, but for other services as well. So one of the most important things, naturally, is getting an accurate measurement. So if you remember just one thing from this session today, is that your technique for measuring blood pressures is more important than anything else. So The image that you can see on the screen there has come from the British and Irish Hypertension Society. They've got loads and loads of resources that you can print out, save on your desktop, anything like that. Put them handy where staff can see them, and it's always just an easy little resource to refer back to. So we will pop all the links into the chat as well for you, and then you can go and get some of those resources. So to split that up a little bit, our patient should be seated nice and comfortably. It's really important that the patient has got their legs crossed. I know a lot of us ladies will sit and immediately cross their legs, but we want a nice even blood flow, and we want all of our muscles to be nice and relaxed. Whereas if you're sat with your legs crossed like I am now, you've got disproportionate tension on each side of your body. So it might affect your reading ever so slightly. Feet flat on the floor, nice and relaxed. Back supported, so a nice comfy chair. If you've not got a comfy chair, maybe just prop it up with a little cushion. And as I said, a nice comfy chair. So there are ways and means, obviously. You could just use a desk chair or anything that you've got in your clinic room, but just make sure that you've adapted that slightly. You've got no wobbly legs and it's not on wheels is definitely an important one, because people tend to just slip around without even noticing, and that movement is going to affect your measurement. So our patient needs to be nice and relaxed. And by relaxed, I mean they've not had any caffeine recently, they've not come straight from the gym, they've not eaten a massive meal in the last sort of 30 to 60 minutes. And I know, as you know, humans, we don't like silence. It can be really uncomfortable, but it's really important not to be chatting to Deborah about her trip to Tenerife last week whilst we're trying to get a blood pressure measurement, because that can also affect your reading. We want our patient's arm to be nice and supported. So if you've got a table next to you obviously have a desk with your computer on. If that table is next to your chair where your patient is sat, they could rest their arm on there with a nice cushion or a pad so they're nice and comfortable. Ideally, we want them at heart height, so we don't want their arm way up in the air, and we don't want them sort of like leaning down, because again, that's going to cause that unevenness and could affect your measurement. Your arm, if it's too high, you're going to get a false low measurement, so it's always the opposite way around. So then if your arm is too low, you might get a false high measurement. And that is just to do with your blood circulation and your blood flow going through your body. So it's really important to get the correct cuff size. Naturally, I'm not expecting anybody to be getting a tape measure out and measuring their patient's arms. However, if you need to do that at first to get used to what the correct cuff size looks like, then absolutely do that. So for a small adult, sort of you're looking at sort of like, especially your older ladies and things that might be a little bit frail, we're looking at 17 to 25 centimetres. Your standard adult one really is 23 to 33. Your larger adults, sort of your 6 foot plus men, they'll range from about 31 to 40. And then naturally you might get somebody that can't have a measurement on their arm, or they don't have upper limbs, then we can refer back to the thigh, and there is nice guidance on that as well. But the most important thing to sort of remember is, if your cuff is too small, you'll get a false high measurement. And if your cuff is too big, you'll get a false low. And that can be by up to about 20 mmHg, and that can be the difference between tipping them into that hypertensive bracket. So what we're looking for, ideally, taking all of the measurements out of it, is the cuff should cover around 80% of that person's upper arm. And an easy way to sort of measure that is take your 2 fingers into the crook of the patient's arm. So your cuff should sit above those 2 fingers, and you should be able to get one of your fingers underneath, so we know it's not too tight. So that's always a quick, easy way to look at it. Naturally, the armpit fold stops the top of the cuff anyway. And then if you've got your 2 fingers at the bottom, that's usually about 80% of the upper arm. Really important to repeat the measurement. Nice best practice is to do at least 2 measurements on both arms. So I know historically it was always you should do your blood pressure measurements on the left arm. It should always be the left, because it's got direct blood flow from the heart, and that's the most accurate. But actually, we need that comparison, and there's not enough evidence out there anymore to suggest that either arm outweighs the other. So if, when you're doing the left arm, and then you move to the right arm, and you find there's a difference of sort of 15 or more, use the arm with that higher reading. But always, when you're going for, when you've chosen your reading, your higher reading, always let the doctor that you're referring the patient back to know of the difference, so they're aware that they need to use the left or the right arm for the more accurate measurements from now on. So when we're looking at our normal blood pressure readings, again, this is from our NICE guidance, and it's in our SLAs and all of the CP information. We're looking for a normal blood pressure, which is lower than 135/85, and it's higher than 90/60. So even though if you're doing a blood pressure measurement and you're happy that it's within limits, it's a normal blood pressure, always provide the results to the GP anyway. We should always be providing all of our results that we're doing to the patient's GP, so they've got a record of that. And never miss the opportunity of that healthy living advice. You know, you've sat and had your consultation, and Jim has said, yeah, okay, I'm happy, I don't feel hypertensive, I've got no symptoms, but I just want to check. And we've checked, and it's normal. However, you know, because Jim's one of your patients, and you know, is a smoker. So you are opening yourself up there to jump in and give some healthy lifestyle advice, even when that reading's normal, because we know that hypertension is missed a lot of the time, and people don't know what the risk factors are and what things cause hypertension. So it's just about building that overall picture for your patient of what things might be a risk factor. So giving Jim advice on stopping smoking, directing him down the right pathways in order to do so. And again, building that relationship with your patients, that they're comfortable and confident to come back to you about healthy living advice. They're confident to come back to you for pharmacy first, etc. So our stage 1 hypertension is higher than 135/85 and lower than 150/95. In these circumstances, we want to be referring the patient to the GP within 3 weeks. Naturally, we can advise patients to do things, and they don't always do things, but that's why it's so important for us to be documenting thoroughly and completing the process properly. So making contact with that GP, whether that's by the NHS shared mailbox, or whether you still prefer to do it as phone calls, whatever you've agreed with your local GP practices works for you and works for them. Make sure that you're just letting them know that you've gathered their reading, you've sort of marked them as a stage 1, and you have given them the advice to follow up with the GP. So then if they've not followed up with their GP, the GP has the opportunity to chase them then. And it's similar when they're referring into your pharmacy first service. That two-way communication, obviously it benefits both parties and the patient because they can be followed up if needed. And we understand that life's busy sometimes, and patients might say, yep, yeah, I'll book one next week, and it slips their mind and they never ever do. So our stage 2 hypertension is anything higher than 150/95, so we're getting up there in the levels now, but lower than 170/115. So for these patients, we want to refer to the GP practice within 7 days, unless there's any red flags present. So we will go through what we're counting as our red flags in a little while. If you are a dispenser, a technician, counter staff, whoever, and you are doing the service and you've gathered this blood pressure, always make sure that the lead pharmacist on site is aware. During opening hours, it's best practice to contact the GP while the patient is physically in the pharmacy to verbally hand over, and advise the patient to book in with their GP for a follow-up within 7 days. And now we're up at the top of the scale. So severe hypertension, anything that is 170/115 or higher, is a same-day GP referral. Again, whilst that patient is in the room with you. If it's out of hours, they've come in at, 5 to 6, which, often they do, or they're presenting with any of the red flags that we'll go through in a second, they need referring to urgent care immediately. Again, whilst the patient is in the pharmacy with you. If it's in opening hours, verbally hand over to the GP, and naturally the lead pharmacist should always be aware of any raised blood pressure measurements that you take. So I've mentioned red flags a couple of times, and these are the things that we're looking out for. If a patient is, even if they're not requesting a blood pressure check, but they're mentioning any of these symptoms to you, then we need to be referring them on to urgent care immediately. So blurred vision or vision loss, confusion or seizures, any severe headaches, chest pain or tightness, shortness of breath, palpitations or irregular heartbeat, they're all for urgent referral. So any blood pressures over 180, over 120 and above need to be sent straight to A&E. If they're unable to get to A&E safely and they've got nobody with them, you need to be ringing an ambulance. So we've got lots of local referral pathways, and the NHS Service Finder is great for this. NHS 111 is fantastic. They can guide patients to a walk-in centre or any other urgent care. We've got our same day GP referrals. If they're unavailable, we're looking at out-of-hours GP, QDOC, CHOC, things like that. A&E for any emergencies as always. And please always document thoroughly where you've sent the patient, where they've decided to go, or if you've gone through NHS 111, and always signpost them appropriately. So I wouldn't expect anyone to be, sat in a consultation and say, yeah, just go to the walk-in. We need to be looking for where the closest walk-in is, how they're going to get there, can they get there safely, and have they got somebody to drive them? Because if they're severely hypertensive, we don't want anybody getting behind the wheel of a car. Naturally, in the world of pharmacy, we know that lots of medications can affect different things. So some of the medications that can affect your blood pressure readings, to name a few, contraceptive pills, which is why we have our regular blood pressure, height, weight, BMI checks for our ladies that are on oral contraception. Steroids create that fluid retention, so they can also give you high blood pressure readings. Again, with our non-steroidal anti-inflammatories, they can also cause some fluid retention, and cough and cold medicines, which a lot of people forget about, but if somebody's had night nurse last night and then come in first thing in the morning for a blood pressure check, that can often alter the reading as well. So it's really important that we're getting a clear, detailed history from our patient, and just asking if they're on any medications, any regular medications, if they've taken any non-regular medications in the last sort of 24 hours, just to build that clear picture of what we're dealing with. And if we do get like a squiffy result, we can then say, okay, well, it might be because, you've had your cough and cold medicine this morning. Why don't you come back when you're feeling better, and we'll redo it for you. So as I've been out and about, a lot of people have sort of said to me, I just don't know how to handle the conversations when patients are asking me, well, what does this mean now? Or, I've got high blood pressure reading in front of me and I'm thinking, I just don't know how to explain the results. So we'll go through some of the sort of counselling and some examples and things that you can say to your patients over the next few slides. So what we're trying to do here is build confidence in our conversations with our patients. So we want to keep it simple, no jargon, no overcomplicating things, no bamboozling their brains and they're coming out and thinking, oh, I can't remember what they said now because I'm really confused. Avoid alarm, we need to be staying calm, keep our calm composure. We don't want to be sitting there going, oh my goodness, okay, your blood pressure's really high, what we're going to do now? We just need to strip that back a little bit. As professionals, remain calm. They're looking to you for reassurance, they're looking to you for guidance. So just try and keep it simple and calm where possible. And be nice and clear. So yes, somebody might have a high result, but when we're explaining that, we're just going to say, okay, your result is high. This is the plan that we're going to go for now. These are the next steps. Are you comfortable and confident with that? Please always encourage your patients to repeat the information back to you so you know that they've absorbed it all. Similarly, if somebody's blood pressure is sort of stage 1 hypertension, you can say, well, this isn't urgent, you do have a high blood pressure, but it's really important to check further and just get you followed up with your GP. So some of the things we can say, explaining a high blood pressure, it's not urgent, but it's important to check further. Motivating that change, so a lot of people are resistant to change, they're stuck in their ways. I've smoked for 15 years and, I like my wine in the evenings and, oh no, well, I've got a desk job, so I don't get time for any exercise. We want to be, instilling that motivational change into people. So saying things like small changes can make a big difference and then handling that resistance. So it's really important that when people are saying, oh, well, I feel fine. It's just a high blood pressure, I feel fine. It's just about reiterating that hypertension often has no symptoms at all, but that's why it's so important that we check. Outlining those risk factors in a nice, calm manner so we're not, causing any havoc, and just letting them know the things that we're looking out for, why we're looking out for them, and why it's so important that we're picking up this hypertension early. So if we've done our patient's blood pressure, and they're falling into the hypertensive category, we know we can then go on to offer the ABPM service, the 24-hour blood pressure monitor. So whilst I've been out and about, I've seen some fantastic examples of clinic checks where the pharmacist or whoever it is doing the check has picked up a high blood pressure and they've successfully managed to translate that into an ABPM appointment. And a lot of the time, don't get me wrong, patients sort of say, well, I don't want that attached to me for 24 hours. So how am I going to shower and how am I going to do this and how am I going to do that? They seem to think it's a real ball and chain, it's going to be really inconvenient. But through the powers of, gentle persuasion, although it is always patient choice, I've seen a lot of really good practice out there of explaining the risk, explaining how simple it is, and it's just 24 hours out of your week. You will be absolutely fine with the machine on for 24 of those hours. So, fit the device and schedule the return time, provide some written guidance for the patient to refer back to, because we know with any new thing, the patient accepts all the information in the room and then they go home and they're thinking, oh, actually, what did they say about this? And how long do I have to have it on for? And what am I meant to do with it? What do with it whilst I'm asleep? So if they've got a nice little cheat sheet, which again you can download off the Hypertension Society website, they've got some information to refer back to. Always give them your number so they can ring you if there's any issues, or and always make sure that your staff that are on site know that Mr. Jones has got an ABPM machine and this is his number and he might ring. And if he does, he's a bit stuck with something. So patients aren't waiting on hold for ages and then getting fed up. Or they know that they can ring you and speak to you directly, and that creates quite a nice relationship as well. So once they've gone away and they've had the 24 hours with their ABPM device, they're going to hopefully come back to you on time and return it. What I would recommend is for those of you that have got sort of high demand for ABPMs, which we are seeing at the moment, which is great, schedule them in a way that if you've only got one machine, if the person that's bringing it back to you from Tuesday is late with it on Wednesday, you've not got them returning at 3 and then it's booked out again at 4 because you've not got time to get the patient in, download all the data, go through the consultation, get it cleaned and set back up for another patient. So just give yourself a little bit of breathing space, and make sure that you're not going to be behind with getting it back. So return the device, confirm it's been used correctly. People often come in sheepishly and say, oh, well, yeah, I did get a bit fed up of it last night, so I just took it off for a bit. And then you say, well, what was a bit? And they go, oh, I can't remember. So you've got a gap in data there. We know that really we only need 12 to 14 hours of data. However, it's best practice to get that full 24-hour picture so we can really see if there's any sort of patterns in spikes, whether that's patterns in the day or patterns going to and from work, picking the kids up and they're having these blood pressure spikes. So always encourage them to keep it on for the full 24 hours. Then we're going to review the data, jump on and access the report, download it, to identify any patterns that we've got, and then explain that clearly to your patient. So you can compare with the nice thresholds that we went through before of your normal stage 1 and 2. And then we're going to give reassurance or advise what the next steps are then. Often next steps, they should always start with your health and lifestyle advice, GP referral if required, and an urgent referral if required. So if you're seeing that there's, 4 or 5 episodes of severe hypertension in there, then we're going straight to urgent referral. If, there's one or two and they're sort of slipping into the stage 1 hypertension, then we need to be letting the GP know again whilst the patient's with you. One of the things that I've heard one of our pharmacists use, the little phrases that they've used is, by the time you leave this room, your GP will have your results. And that provides that confidence for your patient that you've got a really good communication system with the GP. Everyone's on the same page, and they're not going to have to go and explain to the GP, yes, I've had it, these are my results, and that's all taken care of in the background, and patients love that. I would always give them a written copy of the results. They've got that to refer back to. A lot of people like to keep a log of their own results as well. Even with the clinic blood pressure checks, they like to keep a little log of what's going on. And again, they can spot patterns as well of if they are going through a stressful period in life and they're a little bit hypertensive, but then it resolves, they can sort of start to map that out for themselves. And I do encourage people to keep sort of blood pressure diaries and things like that. But obviously, we would much prefer them to be coming into pharmacy to have these blood pressures done than us giving them a machine, a clinic machine, and them not knowing how to put it on properly. And we don't know if they're measuring properly and things like that. So once we've gone through next steps, we want to make sure that patient is engaged, they know what's going on, provide them with a summary of what their results look like, have that lifestyle discussion with them and offer any resources that you've got. There's loads of amazing resources out there, and you can download lots of resources to print out for free. But most people like things on their phone now because we've moved into that technology. So in a couple of slides, I'll show you some helpful resources and things that you can guide patients to that they can access on their phone. And I know I always go on about documentation, and it's the nurse in me, and I apologise. However, please, please, please document thoroughly. Recording farm outcomes, send the referral securely, ideally through NHS shared mailboxes. Note any concerns that the patient might have, and always document any information or guidance or advice that you have given. Lots of patients will then say to you, well, what are my options? And patients do have options. It's always patient choice. And the first option is you can choose to do nothing. I wouldn't advise it as a professional, but you can choose to do nothing. Explain those risk factors and the complications of the untreated hypertension. Emphasize and re-emphasize to create that understanding that the patient probably shouldn't choose the option to do nothing. And then lifestyle changes, we can discuss some lifestyle changes, get you moving more, improve your sleep, cut down your alcohol intake, stop smoking. And a lot of the time, our patients think they're unrealistic or it's not going to fit with their lifestyle or they enjoy these things, which is fine. But then we're going on to medication then. But it's really important to emphasize to your patients that, medication doesn't fix everything and there's no one pill fix all. So even if they do decide for option 3 of going into sort of the realms of medication, they will have to commit to some lifestyle changes. And sometimes it can take 2 or 3 consultations to get through to your patients and get them on board. And a lot of the time, they're sort of sitting there and they've received all of this information. And they need to go away and think about it. And that's fine. We can give them that space to go away and think about it and then come back to us when they've decided. But it's really important to make them very clear that if they do choose to go down the medication route, if suited, that they will still have to commit to some of these lifestyle choices. So we've mentioned a lot about lifestyle changes, and as I mentioned, we're finding that patients prefer to have things easily accessible on their phone these days. So the NHS has put a lot of money into lots of various different apps and things like that patients can easily access. We've got the NHS Quit Smoking app, the Couch to 5K, the Weight Loss Plan app, BMI Checker, Food Scanner, which is a great one, because when we're talking to patients about reducing, their salt intake, their fat intake, etc., they can sort of think, well, I don't really know how to do that. But with that scanner app, all they have to do is literally scan the barcode and it'll give you all the information of what's in the product, which is amazing. Couch to 5K has been around for ages now, hasn't it? But has actually had a lot of success. I met a patient not long ago, actually, three weeks ago, And she was in her late 40s, and she'd been diagnosed with stage 1 hypertension, and she'd got some of the mums, so she had older children now, and she got some of the mums every Tuesday after they dropped the kids off at school. They do the Couch to 5K, and they'd all completed it, which I think was amazing. So it's just about, making it realistic, making it accessible, and just sort of like encouraging that change as well. So on to some case studies. So, as I say, when I've been out and about on some visits, people have sort of said, well, it's all well and good having the information on the paper in front of me, but I don't know how to put it into real life practice. So, these next couple of slides will go through some case studies, and we'll just sort of go through and chat about some of the things that we should be doing. So, a 52-year-old man comes in to buy cold and flu medication, and you, as a counter assistant, are thinking, oh, you look like you might be over 40. That's great. So you're going to ask him politely how old he is. So have you had your blood pressure checked recently? And he's going to say no, no. Have you got a family history of hypertension sort? And he's going to say no, don't think so, because that's the usual answer, isn't it? No, don't think so. He said, have you got 5 minutes spare? It'll literally just take you 5 minutes. And he's going to go, yeah, okay, then I'll have my blood pressure check in. And the key one is it's free because that's what people love. They love that it's free. And that will often be the sway. If you've got somebody on the fence, just mention that it's free, and they're definitely more likely to just stop 5 minutes and have it doing. So you do his clinic blood pressure reading, and he's sitting at 168/96. He says he's never been told he's got high blood pressure, and there's no family history. And he's got a BMI that's, roughly about 29. If we've not got time for patients in a rush, and we don't have time to be doing BMI, height, weight, calculating that, etc., it is fine. Just get that blood pressure reading. And then we know where we're sitting at least. And he's got no symptoms, which when we went through our red flags before, we know that he's got no blurred vision, he's got no increased heart rate, and he's not experienced any dizziness or anything like that. So what are we going to do? So under the service, the one single elevated reading is not a diagnosis of hypertension. So that's why it's really important to do our repeat blood pressure readings. So repeat the blood pressure after 5 minutes. And if it's still elevated, both arms, remember, if it's still elevated, then we're offering an ABPM if you've got one available. If it's booked out, you could offer for the patient to come back tomorrow or come back later today when we know we're going to have it back. Or if that's not convenient, you can always refer back to the GP. So we're referring back to the GP within the 7 days because he's got no red flags and he is slightly hypertensive. Naturally, we're always going to make the lead pharmacist on site aware because ultimately responsibility lies with them. We're going to contact our GP with the patient while they're there on site to verbally hand over and advise our patient to book a GP follow-up within 7 days. So this is the perfect time to have little printouts or things on your desktop of things that you can just refer back to, like the NHS Quit Smoking app. If patients have got like a little slip or something just to take with them, once they sit down later and think about it, then they're more likely to be sitting and have a look and actually sort of look into what they're going to do to make these changes and then come back to you. Second case study. So we've got a 38-year-old female referred from the GP, and we know that if you're sub 40 but referred by the GP, it's our local agreement that we will accept those patients. She's reported headaches and work-related stress. She doesn't smoke, she drinks alcohol on occasion, but she does have a family history of CVD. Her blood pressure is sitting at 133/80. So as I've mentioned, although she's under the age criteria, and I know the SLA states that it's the pharmacist's discretion whether to do so, given the family history, I would absolutely recommend that we're doing that check. And as I say, we've across Lancashire and South Cumbria, we do have that agreement that we will see patients that are under the 40 mark. So at this stage, we don't need to offer an ABPM. We don't need to label her as hypertensive because she's sat just underneath. What we do need to do is just as important though. So provide that health lifestyle advice, reducing salt, increasing exercise, reducing her alcohol. If she's drinking caffeine, then we need to be having a look at the conversations around switching to decaf or reducing the amount of caffeine she's having. Encourage her coming back for rechecking, because that's really important. And again, build those relationships with your patients and that confidence that they can come back to you. She can come back for a check sort of every 3 to 6 months if required. And just emphasize how important it is that she comes back for that regular checking, given that she is just underneath the hypertensive mark and, you know, she has got that family history. Create that safe space that she can come back to. So the case finding service, it's not just about diagnosing. We're not jumping in desperate to label someone as hypertensive. What we need to be looking at for these patients that are sitting slightly below is we're looking at prevention, especially for those patients that mention they do have a family history or they've got, you know, other factors in their life, stress, lifestyle factors, etc., that could cause their blood pressure to be creeping up slightly. So we want them to be coming back, we want to keep on top of it, we want to be checking regularly, and we want to be doing everything that we can to prevent that hypertension, obviously then turning into CVD. As I mentioned, please document thoroughly. CPPE have an excellent module on documenting in clinical records, which is fantastic. So as a nurse, I always tend to use SPAR. But you can use any model you want as long as it covers all of the basic sort of necessities that we need from you. So I use situation, background, assessment, and recommendation just because it's really clear and it's a nice format for patients as well. So as you're sort of writing your notes briefly whilst the patient's in the room, it gives you that clear set out of what guidance you're giving them, what the plan is next, where you're signposting them to, and what their results mean. So that's always a really handy one. I know there's lots of AI devices and, you know, applications and things coming through at the moment, and we did actually recognise the other day that one of them does use SPAR. So although, you know, computers are taking over, please be following a good pattern for documenting and feeding that back to the GP. And again, if you're, you know, you're proving that you can document thoroughly, you're referring the information back to the GP, that GP is then in turn going to build trust in you and your pharmacy team as well, that they can send patients to you, they're going to get the assessment and the care that they need, but they're going to get a full comprehensive report afterwards, so they know where that patient is up to as well. So overall, we're looking at the role of the community pharmacy, and it's really clear that in community pharmacy, we're the perfect place to identify the undiagnosed. The footfall we get across our pharmacies, you know, when they're coming in for X, Y, and Z, we're in the perfect place really to just pick those patients out of the population that might have no other reason to have their blood pressure checked. But we've picked them out in the community and checked them, and I would be interested to see in sort of the next 5 years what proportion of hypertensive patients are picked up in community pharmacy, because I think it's an amazing service and we're situated perfectly to deliver it. So prioritise your high-risk patients, those that are coming in or being referred that do have a family history of CVD. Use the ABPM appropriately. As I say, make sure that you're giving yourself enough time to get the machine in and reset, ready for your next patient. Know when to refer urgently, whether that's an urgent referral back to the GP in hours, or whether that's an urgent referral to urgent care or a walk-in centre out of hours. If you are a pharmacy that regularly has locum staff, it's always helpful just to have a little list on the wall or on the desktop of local walk-in centres, urgent care providers, etc., that they could send patients to. And don't forget that prevention work. You know, I know the hustle and bustle around healthy living pharmacies has died down ever so slightly, but this is the perfect opportunity to be giving all of that healthy living advice. So all of your resources that you've got, you know, the previous national campaigns that have been done, they've all got amazing resources on there. And if in doubt, jump on the App Store. because there's so many things on there that the NHS have developed, so many apps, that if you type in sort of NHS healthy living, it brings up a whole host of different apps that you can direct your patients to. So I've mentioned a couple of times about popping things on the wall or saving them on the desktop. So these are some resources from sort of like Nice Guidance that, as I said, you can download them, you can print them, but if you visit the link directly, and we're going to pop some links in the chat again, there's lots of interactive versions of these as well, where you can pretty much say, right, this patient is here, this is their blood pressure, and it will guide you through the process flow. But don't forget, it's not always about following step by step. It's about looking at the patient in front of you, and gathering that full picture, all of that, all of the things that are going on in their life, the medications they're on, get a really good comprehensive background so you can paint a full picture to then refer back to the GP. As I say, there's some more here, and all the information is in line with Nice Guidance, and these are the nice interactive ones. They're great. So now's your opportunity to pop some questions in the chat. I have pulled some frequently asked questions off the CPE website, and I've put a couple in of things that I've been asked whilst I've been out and about. But the Q&A button is up there, or pop them in the chat if you're not familiar with using the question and answer button. That's fine. But whilst we wait for some of those, if you've got any, I'll just pop through some of the ones that I've got saved. So who can provide the service? Now I'm really flying the flag here. I want everybody to provide in the service. So as I've mentioned, please, pharmacists, don't feel like you have to take on the whole responsibility of this service. Anyone that's suitably trained and competent and confident can provide the service. So pharmacists, technicians, other non-registered members of the pharmacy team, it would be great to hear some stories when I'm out next that we've managed to a big push and we've got loads of staff trained and everyone's confident. Even if you're not confident in delivering the service and doing the blood pressure checks, it would be really nice for staff to build that confidence in even just pinpointing who that's visiting the pharmacy would be suitable for the service, and they're doing that sort of in-store triaging and letting the pharmacist know that this patient would like a blood pressure check. Can you provide clinic checks and not ABPMs? Unfortunately, no. So we have had some pharmacies providing the clinic blood pressure checks, not doing the ABPM. They've not been signed up to the hypertension case finding service as a whole, but then obviously they're making a loss on doing those clinic blood pressure checks, so because they can't claim for them. So the whole service requires you to be doing the clinic checks and the ABPMs. This is common. If a patient refuses to have an ABPM, what am I doing? So ask them to make an appointment with their GP within 3 weeks. The likelihood is, if they've refused an ABPM off you, they're probably not going to seek advice from their GP either. But please make sure that the clinic blood pressure check the result that you've gathered from them is sent as a notification and a referral to practice the same day, so they can then chase them up. Similarly, if that patient then comes in next month for their prescription again, it's about having that confidence in saying, did you book in with the GP? And they're going to say no. And then you're going to say, okay, how about we just check your blood pressure again and make sure that it's not gone up, it might have gone down. And then it's just, again, about building that rapport and that confidence with your patients. But as long as we've clearly documented that the patient has refused, but this is the advice we've given them, we've made a referral, everybody's aware, then you've covered yourselves as well. Do you have to provide the patient's GP practice with the reading if they're normal? Yes. So any blood pressure reading that you take, whether that's a clinic blood pressure or an ABPM, please always notify the GP, because they need to have that on their patient records too. So another one that I've sort of been asked is, well, the diastolic's fine, but the systolic's high, or vice versa. So try not to look at the blood pressure as a whole. Any reading, whether that's systolic or diastolic, if they're abnormal and they're falling into those hypertensive categories, then we need to be referring them on or providing the ABPM. or whichever stage of the service they're fitting into. So try, even if their systolic is fine, but their diastolic is high, I'd still expect you to follow that process of escalating. Can we just communicate the results with the patient's GP? The difficulty is, and I know that some of you out there are still doing phone call sort of handovers with your GPs, which is great because a lot of you've got backdoor numbers and that's really, helpful. However, those phone calls aren't always reliable. You're spending a lot of time on the phone trying to get through to GPs. So we need to be, doing that in a confidential way. Ideally, we want them to go into NHS shared mailboxes or whatever you're choosing to do. So especially transcripts need to be sent for every single patient who's had an ABPM. They need the clear patient details in order for it's probably not going to be the GP, but for the admin staff to link that to the right patient and pop it in their patient notes. So I would always recommend you doing written communication with your GPs. However that goes, whether it is direct to the GP or it goes to the admin staff, then at least you've got a record of, I have gathered this result today, I have given this information today, I've given this advice today, and advised the patients to do X, Y, and Z, and you've completely covered yourself there. Whereas information on phone calls could be forgotten, information could be misheard and written down wrong. So if it's clear from your end, it's clear on their end, and there can be no mistakes from that. Can I referral from a GP practice for blood pressure checks for any age? So yes, in our area, as I've mentioned, across Lancashire and South Cumbria, we have got an agreement that if the GP practice feel it is necessary, then they can refer into the service, even if they're under 40. So this also applies for obtaining clinic blood pressure checks for things like oral contraception. Again, we can claim for these parts of the service, so there is a benefit. It's not like we're doing it for nothing. But yeah, all of these sort of extenuating circumstances can be referred into the service at the GP's discretion. And final one, and I come across again, I've literally just put this on today because I come across this last week. A homeless patient had entered the pharmacy. They naturally didn't have a GP, but were concerned about their blood pressure. They fit the criteria of the service. They were over 40. They did have a family history of CVD, and it was a question I got asked on site. So yes, the service was provided, and then the pharmacist very kindly gave them options of GP surgeries they could register with, and sort of the details of that as well. And then we wrote down their clinic blood pressure results and advised them to go to the GP with those, get themselves registered. But in the case where they were severely hypertensive or needed an urgent referral, because they've not got a GP, we'd just be directing them straight to urgent care. But it was really nice to see that full wraparound care for that patient of, we can still do the service, this is what you need to do to get a GP, and they were really supportive for that patient. And these are the brilliant examples that I'm seeing all the time whilst I'm out and about on visits, seeing all of your lovely faces that I can't see now. And that is the end of the session. As I say, if you have got any questions, can't see any coming through, pop them in the chat, and then, or you can pop them in the chat or the Q&A, and then we've got a lovely QR code on the screen there. If you would kindly leave me some feedback, that would be amazing. Our contact details are there as always. You know how to get in touch with us, and I will be doing my next round of visits soon. So if nobody's got any questions, I will let you go. Thank you very much. As I've mentioned, the recording will be available. We'll pop it on YouTube and we'll let you all know when that's ready to go. So thank you very much, everyone. See you later.